Hi, my name is Dr. Abid, and I'll be discussing with you guys the basics of ECG. ECG is a very, very huge topic, but we will try our focus and we'll focus on the things that are needed in PLAB. Right. So let me. Everyone can. Yes. Everyone can see my screen, right? Hello. Everyone can see my screen. Yes, perfect. And everyone can hear me. So let's start with the basics of ECG. ECG, it is an electrical or graphical representation of electrical activities that are basically going on in the heart. Electrocardiography. I basically divide studying ECG in three main parts. Number one, ECG itself, like ECG has its different parts. ECG itself. Number two, the leads that we use in ECG. And number three, the paper that we use in ECG. So I will try to summarize my whole thing in these three steps. I will start with the paper first. Why is it important? It is important because most of the things in most of the abnormalities, we have to know that what's going on regarding the time. Like, let's start with the paper. It's a simple graph paper. It has small boxes and big boxes. So one small box is equal to 0.04 seconds, right? And in one big box, there are five small boxes, and that one big box is equal to 0.2 seconds. And as it is an electrical activity, so one small box is equal to 0.1 millivolt, right? One small box is equal to zero point zero seconds. That is a representation in time. And this is the electrical representation, whatever is going on. Fine. So normally we run ECG whenever you guys go through or see an ECG. The first and foremost thing is start with the name of the patient, sex of the patient, and the reason why did we do that ECG. Fine. And after that, do read the instructions or do read the paper speed and voltage used. Normally the ECG is done on the speed of 25 millimeter per second with the voltage of 10 millimeter per 1 millivolt. Well, this is important. Sometimes if you go through the ECG and the speed is high or low, you cannot, or and you go like you say that it's a bradycardia or tachycardia. It can happen. Number two, if the complexes are tall or the complexes are small, maybe um, maybe the voltage has been reduced or increased. So keep this in mind. Normal ECG is done on 25 millimeter per second with 10 millimeter per 1 millivolt of the speed. So as we discussed that the small boxes and big boxes, we have discussed that one small box is almost 0.04 seconds, and one big box is equal to 0.2 seconds. And with electrical correlation, one small box is equal to 1.1 millivolt. So It gives a rough idea that 5 small squares is equal to 0.5 millivolt, or 10 small squares is equal to 2 large squares, which is equal to 1 millivolt. Okay, this was about the paper. Now, coming to the as we discussed, coming to the leads. Well, we normally use 12 leads in ECG. Among these 12 leads, let me go there. Leads, we normally use 12 leads. Among these 12 leads, we have 6 limb leads and 6 chest leads. What are the limb leads? 1, lead 2, lead 3, AVL, AVF, and AVR, right? And what are the chest leads? V1, V2, V3, V4, V5, and V6. This gives us an electrical activity of the whole heart. Normally, for to understand the pathology, we use a combination of these leads. Like definitely, we are doing the ECG to understand what's going on in the heart. Wait. You guys can hear me. I'm so sorry. You have to put your message in the chat box. If anyone wants to say something, I'm so sorry for that, but you have to do that. So, what are the combinations that we make about the leads? One AVL with V5 and V6. This gives us the lateral aspect of the heart. Always remember with this AVL that this is the lateral aspect of the heart. Then there comes 2, 3 AVF. 2, 3 AVF, always remember with F, this is the inferior aspect of the heart. 1 AVL plus V5, V6 was the lateral aspect of the heart, and 2, 3 AVF, this is the inferior aspect of the heart. Now coming towards V1 to V4. This is normally called the anterior septal or anterior aspect of the heart. Okay? 1 AVL plus V5, V6 goes shows us the lateral aspect of the heart. 2, 3 AVF shows us the inferior aspect of the heart, and V1 to V4, we can say it is the anterior septal or anterior aspect of the heart. Why is it important to divide these like this? It gives us a rough idea. It gives us a rough idea re regarding the blood supply of the heart, such as if there is any abnormality in 1 AVL, V5 and V6. So we will say it is a lateral MI. Lateral MI, and this lateral lateral aspect is lateral aspect is supplied by left coronary artery. Basically, the branch of left coronary artery, that is left circumflex artery. Left circumflex artery supplies the lateral aspect of the heart. So if there is any abnormality or any issue with this left coronary artery or left circumflex branch of left coronary artery, the pathology will be in 1 AVL, V5 and V6. Okay. If now 2, 3 AVF. This is the inferior aspect of the heart and it is supplied by right coronary artery, basically right coronary artery. And let's be more precise, posterior descending branch of posterior descending branch of right coronary artery. Posterior descending posterior descending branch of right coronary artery. We have covered lateral, we have covered inferior. Now coming towards the anterior. As we discussed, it is V1 to V4, but for the sake of blood supply, we sometimes converge it to V2 to V4. So this is supplied by left anterior descending artery, more specifically diagonal branch of left coronary artery, left anterior descending artery. So far we have discussed the blood supply. 1 AVL, V5, V6. This is the lateral aspect of the heart supplied by left coronary artery with the branch left circumflex artery. Inferior aspect of the heart 2, 3 AVF, that is right coronary artery supplying with the help of posterior descending branch. V1 to V4, that is the anterior aspect of the heart and it is supplied by left anterior descending artery with the help of a diagonal branch. So till now we have cleared or we have covered about the paper leads. Now coming towards the ECG itself. So ECG had how many ECG had has different parts. There is an isoelectric line, then P wave, which is basically P wave is basically ventricular depolarization. Ventricular depolarization. Then there is a first after P wave, first downward deflection. After P wave, the first downward deflection, that is first negative deflection is always a Q wave. Sometimes we mix it with S wave, but basically it's not. So after P wave, the first downward deflection is a Q wave and after P wave, the first upward deflection is R wave. After R wave, the other downward deflection is S wave and then there is an isoelectrical line and then is a T wave. So the ECG has P wave, QRS complex and T wave. So from P wave to R wave, this is area is called PR interval. Sorry, I forgot. This is ventricular atrial depolarization. P wave is atrial depolarization. QRS complex shows ventricular depolarization. The ST segment basically tells shows it's an isoelectrical line, and it basically shows ventricular depolarization and ventricular repolarization, right? And yeah, and there's a QT interval between this. There is something else. Anyways, so and T wave is ventricular repolarization basically. Is everything clear till now? So we discussed so far that ECG has P wave, Q, R, S, and T waves. The 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 distance between P and R wave is called PR interval. Now we will discuss it individually, like starting with the P wave. Normally, whenever you guys are focusing on, I will not go in detail at the moment, but I'll just give you a rough idea. Whenever you guys are focusing on reading the ECG individually, then what will you do? Start with the P wave. What will you see first? Is there a P wave present? Such as sometimes in certain ECGs, it's not present, like hyperkalemia maybe, the P wave is absent. So first, is it absent or present? Number two, the normal intervals of normal sizes of the waves, such as the P wave is normally 2 to 3 small squares. That is, the P wave is 0 point is in between 0.08 to 0.11 seconds. Okay, the PR interval, let me write it here clearly. P wave is normally 2 to 3 small squares. I'm not going to go in detail individually. Right now I'm just giving you a rough idea how to interpret it, right? Which is 0.08 to 0.11 second, and this is showing ventricular depolarization. This is P wave. Now coming to the PR interval. Normally the PR interval, that is 3 to 5 small squares, which is 0.12 to 0.2 seconds. What does this PR interval basically shows? This is the normal AV nodal delay. As we know, the impulses generated in SA node travel all the way from atria and then stop at AV node, SA node, AV node, and then it is distributed further down to the ventricles. So this AV nodal delay is basically PR interval, which I already told you that it is 0.12 to zero point 0.2 seconds, right? 0.20 seconds. Then coming towards the QRS complex. What is QRS complex? As I already told you, it is ventricular depolarization, and we are discussing about the normal limits of it. The QR complex is usually 1.5 to 2.5 small squares, which is basically 0 0.0, which is 0.06 to 0.11 seconds. QRS complex. So far we have covered P wave, PR interval. Now we are on QRS complex, which we told that which we discussed that it is 1.5 to 2.5 small squares, which is almost 0.06 to 0.11 seconds. These are the normal limits which in between these limits we will see or we will interpret the ECG. After QRS complex comes the ST segment. So ST segment basically is an isoelectrical segment. If you see on normal ECG, there we go. Look, this is an isoelectrical line. The whole ECG circulates around this. This is upward deflection is a positive deflection and downward deflection is a negative deflection. So basically ST segment, this is the ST segment. It is an isoelectrical line. And this basically shows all the ventricular depolarization and repolarization, the time between the ventricular depolarization and repolarization. So, and then there is a T wave. Yes, there comes a T wave. Then there is a T wave. So our main focus will be right now this normal values. Okay. As as discussed in our resources, there is when we start interpreting an ECG, the first step it says rate of it is rate. Now, how will we determine the rate? The first and foremost thing that we should do is the rate. The easiest way, okay. The easiest way to determine the rate is RR interval. You have to find out, the consecutive R waves, and then you have to count in between those R waves the number of boxes in between the R wave, number of small boxes, the big boxes, sorry, number of big boxes in between those R waves, and then divide that number by 300. Let's say 1, 2, 3, 4, 5. So in between these two R waves, there are 1, 2, 3, 4, 5. 5 big boxes. So I will divide 300 by 5. This will give me a heart rate of 5, 6, 30, 60 beats per minute. So the issue with this is that this can only be done if your rhythm is regular. So, okay. If the rhythm is regular, you have to, you can do this method to calculate the heart rate. If, what if the rhythm is irregular, what should be done now? Then you will see whether it's regularly irregular or irregularly irregular. Anyways, we'll go in detail later on, but for that there's a very simple method, card method. Most of the people may know about it. You just pick a page, or you just pick a normal, no, sorry, that's the rhythm. How will you differentiate between this regular and irregular rhythm? regularly irregular rhythm and irregularly irregular rhythm. There's a card method. You just pick up a card or a plain paper and you just mark the two consecutive R waves on that paper, and then you run that specific part on the entire lead 2 of your ECG. So this will give you a rough idea whether the rhythm is regularly irregular or irregularly irregular. So how to find out the rhythm of irregular ECGs? In irregular ECGs, what will you do? You guys might have heard 10 normally 1 minute strip, that's called. That is, you you find out QRS complexes along the entire ECG of you take an ECG and you count the QRS complexes in almost 50 um 5 6 30 yes, 50 big squares, and the number of complexes that are present in between those 50 big squares, then you multiply it with 6, then it gives you a rough idea of the rate. This is what you can do with irregular ECG, or irregular, wherever you find it, irregular rhythm. You can do this, or you can count the QRS complexes of 30 big squares and then multiply it uh, with 10. Sorry, there we go, 10. So this is a 6-second strip and this is a 10-second strip. I hope I made my point clear over here. If you guys have any questions, just please send it in the chat box. So for regular rhythms, it's easy. You will divide the big count the big squares between two RR intervals and then divide that amount with 300. It will give you the normal heart rate. But what will you do in irregular rhythms? In irregular rhythms, you will count the QRS complexes within 50 big squares and then multiply it with 6. This will give you an estimation of heart rate within 1 minute, per minute basically. So keeping in mind that the ECG paper is run 25 millimeter, the normal speed that we discussed, 25 millimeter per second at 10 mm per 1 millivolt. If the paper is running on this speed, then you can get an idea of the heart rate like this. So this is how you will find the rate of the normal ECG. We discussed the rhythm. You will see there's a card method. Uh, this is the card method that you'll put. You'll take a clean paper or a card, and you will put it on a consecutive RR waves, and then you'll mark that paper. Like let's say this is the R wave, this is the R wave, and you'll run it across the whole ECG. You will find out the rhythm of the that ECG. Now the third step that is axis of that ECG. Yes, we have covered. Yes. Now coming towards the axis. For axis, again, we should know what is the normal axis of the heart? The normal axis of the heart lies in between plus 90 degree to minus 180 degree. Okay, the normal axis of the heart lies in between plus 90 degree plus 90 degree to minus 180 degree. This is the normal axis of the heart, like this. What happens? This is AVR, AVL, AVF. You guys might find this picture in the resources if anyone has it. Lead 1, lead 2, lead 3. Okay, so this is 0 degree, this is 90 degree, this is somewhat 60 degree, this is 120 degree, and this is minus 150 degree, and this is minus 30 degree. AVR and AVL. AVR is at minus 150 degree and AVL is at minus 130 degree. So normal axis of the heart lies in between. This is the normal axis of the heart, because if you how is it how is this thing determined? Because if you see the placement of heart, the heart's tip is almost somewhere like this. So this is how this thing is interpreted. So as we discussed, lead 1. So in norm, okay. Now, as we said, this is an isoelectrical line. Upward deflection is called positive deflection, downward deflection is called negative deflection. So at 0 degree, lead 1 will be somewhat positive because it is under the influence of positive degrees, 0 degree and 90 degree. And lead 2 will be also positive normally. And lead 3 will be plus minus positive. We can say it is sort of isoelectric, not exactly isoelectric, but if you see the RS ratio, so it will be almost um, neither more positive neither more negative if you cross check it. So this will be the normal uh, lead 3. So as we discussed earlier on, okay, I guess the meeting will be ended in less than 1 minute. So I'll okay. We were discussing about the axis. We discussed earlier that the axis of the heart, of normal heart, is between plus 90 degree to minus 180 degree. So it lies somewhere around here. This is what we discussed about, depending on the variation on the patient to patient or person to person. So in normal ECG, the AVR will mostly be negative. That means the electrical presentation of the heart in AVR will be negative. It will be below the isoelectric line. So what happens? How will you? Yes. How will we? Uh, Wait. Let me go to the resources. Yes. Now there are two par types of deviation: left axis deviation or right axis deviation. So, as we discussed earlier on, normally lead 1 plus lead 2, both of them are positive. This is lead 1, this is positive. This is lead 2, again positive, because there are no negative degrees in this area. So, normally lead 1 and lead 2 will be positive. What will happen in left axis deviation? In left axis deviation, the normal axis of the heart that was in between plus 90 to minus 180 degrees, that normal axis of the heart will be deviated between towards the left, and in between it will lie in between minus 30 degrees to minus 90 degrees. So if we see this graphical representation, let me make it again. I'm so sorry. Uh, this was AVR, AVL, AVF. So AVL was minus 30 degrees, AVR was minus 150 degrees, AVF was positive 90 degrees. It is positive. Here lies lead 1, which is at 0 degrees. There we go for the lead 2, which lies at 60 degrees. That is positive 60 degree. And there we go for the lead 3, which lies at positive 120 degree. Sorry, positive 120 degrees, right? So what happens in left? We were discussing left axis deviation. So the axis of the heart from plus 90 to minus 180, it lied here somewhere. It is shifted towards minus 30 to minus 90. So what will happen? Wait. Sorry. So what will happen, as normal in normal heart axis? In normal heart axis, the lead 1 was positive, the lead 2 was positive. But now the heart's axis has been deviated from this positive area to the negative area. That is between minus 30 to minus 90. So what will happen? The lead 1, the lead 1 will left axis deviation. The lead 1 will stay positive, but lead 2 becomes negative. And along with lead 2, the lead 3, which was sort of isoelectric, it will also become negative because the heart axis has been deviated towards negative side. So in left axis deviation, lead 1 is positive, lead 2 and lead 3 will be negative. Okay? What happens in right axis deviation? In right axis deviation, the heart's axis is deviated between plus 90 to minus 180, plus 90 degree to minus 180 degree. So what will happen then? The lead 1, become negative, which was normally positive. The lead 1 becomes negative and lead 2 will become more positive. Or there's another thing. Yes, there is another thing, or AVF, which we already discussed. The AVF will also become negative. The AVF will become positive. Normally the AVF is negative, but the AVF will become positive. So what happens in right axis deviation? Lead 1 becomes negative. Normally the lead 1 is positive, and this was lead 3. Lead 3 and AVF will become positive. I hope you guys understood till now. So far we have discussed rate, okay, so far we have discussed rate, rhythm and axis. So let's conclude the axis. In left axis deviation, what will happen? In left axis deviation, how will we interpret it? The lead 1 will be positive, whereas lead 2 and lead 3, they will become negative. Right axis deviation, what will happen in right axis deviation? In right axis deviation, the L1 means lead 1 and right axis deviation, and lead 1 becomes negative, and the inferior leads, that is 3 AVF, they will become positive. So this was our axis deviation. From axis deviation, yes, basics, ECG interpretation, ECG. Okay, fine. So far, we discussed about the ECG paper, ECG leads, and ECG itself up to rate, rhythm, and axis. Further, we will go step by step in the ECG and this will discuss different parts P, Q, R, S complex, P, PR interval, ST segments, and T wave. We will discuss it one by one. Right now, I guess this was the basic idea, uh, how to interpret it easily, like how will you go for it. The other side or this aspect of ECG is quite detailed, so we can discuss it later on in other discussions, uh, individually with the diseases, and I hope that will be more helpful. Right now, I would like to conclude my today's discussion. uh, if you guys have any questions, please ask me in the chat box.